Welcome to this pediatric nursing masterclass focused on leukemia. This video targets preparation for exams like NORCET, RRB, ESIC, DMER, and DHS, covering golden points, visuals, and previous year's questions. What is leukemia? It is a malignant disease or cancer of the bone marrow and lymphatic system. It is characterized by the unrestricted proliferation of immature and non-functional white blood cells, also known as blasts. These cells crowd out the healthy cells. Leukemia is the most common childhood cancer, accounting for about 30% of all cases, with a peak onset between 2 and 5 years of age. Risk factors include genetic syndromes like Down syndrome, radiation exposure, and exposure to chemicals such as benzene and pesticides. Leukemia is classified based on cell lineage, lymphoid versus myeloid, and maturity, acute versus chronic. Acute lymphoblastic leukemia, or ALL, is the most common, while acute myeloid leukemia, or AML, affects myeloblasts with a poorer prognosis. Acute lymphoblastic leukemia, or ALL, involves the uncontrolled proliferation of immature lymphocytes. It has a peak age of 2 to 5 years and a high cure rate with modern chemotherapy. Good prognosis factors include age 2 to 10 years and a white blood cell count under 50,000. Acute myeloid leukemia, or AML, is a malignancy of the myeloid cell line. It requires more aggressive chemotherapy and often a bone marrow transplant. A key note is that chloroma, a green tumor, is sometimes seen in AML. The pathophysiology of leukemia can be summarized as the crowded house. A genetic mutation leads to uncontrolled blast cell growth, crowding out normal cells in the bone marrow and resulting in pancytopenia, which is low counts of red blood cells, white blood cells, and platelets. A quick review of key concepts. The most common type in kids is ALL. The associated syndrome is Down syndrome. The peak age of onset is 2 to 5 years. Clinical manifestations are often described as the triad. 1. Anemia due to low red blood cells causes pallor and fatigue. 2. Infection due to neutropenia causes fever and frequent infections. 3. Bleeding due to thrombocytopenia causes petechiae and bruising. Signs of organ infiltration include bone pain, often mistaken for growing pains, hepatosplenomegaly, and swollen non-painful lymph nodes, known as lymphadenopathy. Central nervous system involvement can present with signs of increased intracranial pressure. Diagnostic evaluation begins with a complete blood count, which usually shows anemia and thrombocytopenia. A peripheral blood smear is crucial as it reveals the presence of blast cells, which are immature cells that should not be in the circulating blood. The gold standard for diagnosis is bone marrow aspiration, which shows hypercellular marrow with blast cells. The safest preferred site in pediatrics is the posterior superior iliac crest. The nurse assists with positioning and post-procedure care. A lumbar puncture is performed to check for CNS involvement and to therapeutically administer intrathecal chemotherapy. The child is positioned in a C-shape or fetal position. Post-procedure, the child must lie flat for 4 to 8 hours to prevent a spinal headache. To quickly review diagnostics, the confirmatory test is bone marrow aspiration, preferably at the posterior superior iliac crest. The test for CNS involvement is lumbar puncture with CSF analysis. Leukemia treatment involves a total of 2 to 3 years of chemotherapy divided into 4 phases: induction, CNS prophylaxis, consolidation or intensification, and maintenance. This phased approach maximizes kill rate and minimizes resistance. Phase 1, remission induction, lasts 4 to 6 weeks. The goal is complete remission, which means less than 5% blasts in the marrow. This is a highly intense phase where the child is at massive risk for infection and bleeding. Common drugs include vincristine and corticosteroids. Phase 2, CNS prophylaxis, is an exam priority concept. It is necessary because the blood-brain barrier prevents IV chemo from reaching the CNS, a sanctuary site for leukemic cells. Treatment involves intrathecal methotrexate, sometimes with cranial radiation. Phase 3, consolidation, aims to eradicate residual cells and prevent relapse using periodic chemotherapy pulses. Phase 4, maintenance, maintains remission for 2 to 3 years, often using oral chemotherapy, allowing the child to return to school. Hematopoietic stem cell transplant, or HSCT, is indicated for relapsed ALL, or high-risk AML. Allogenic transplants use a donor, like a sibling, while autologous uses the patient's own cells. The process involves destroying the marrow with high-dose chemo and infusing new stem cells. Nursing diagnosis 1 is risk for infection related to neutropenia. Nurses must monitor the absolute neutrophil count. A key warning is that fever, a temperature above 38 degrees Celsius, is often the only sign of infection and is a medical emergency. Neutropenic precautions, or reverse isolation, are critical. This includes strict hand washing, no sick visitors, and a private room. The environment should exclude fresh flowers or plants due to aspergillus risk. The diet must be low bacteria with only fully cooked or peeled foods. Nursing diagnosis 2 is risk for bleeding related to thrombocytopenia, which is a platelet count below 100,000. A count below 20,000 presents a risk of spontaneous bleeding. Assessment involves checking for petechiae, bruises, and any blood in urine or stool. Bleeding precautions involve using a soft toothbrush and avoiding flossing. Avoid all IM injections, and if necessary, hold pressure for 10 minutes. Use acetaminophen for pain, and strictly avoid aspirin and NSAIDs as they interfere with platelet function. Nursing diagnosis 3 is mucositis and nutrition. Mucositis is painful ulceration of the GI tract due to chemotherapy. Interventions include frequent mouth care, normal saline or sodium bicarbonate rinses, and a bland, soft, cool diet. Viscous lidocaine may be used before meals. Common chemotherapy side effects, known as toxicities, affect rapidly dividing cells, leading to myelosuppression, alopecia, nausea and vomiting, and mucositis. Tumor lysis syndrome is an oncologic emergency caused by the rapid breakdown of malignant cells. This causes hyperuricemia, hyperkalemia, hyperphosphatemia, and hypocalcemia. Management requires hyperhydration to flush the kidneys and allopurinol to reduce uric acid. Let's review nursing care. The primary sign of infection is fever. Avoid aspirin as an analgesic. Use paracetamol. The recommended mouth rinse solutions are normal saline or sodium bicarbonate. Question 1. Which of the following is the most common type of leukemia in children? Question 2. The definitive diagnostic test for leukemia is. Question 3. Which drug is primarily used for CNS prophylaxis in leukemia? Question 4. A child with leukemia on chemotherapy has a temperature of 101 degrees Fahrenheit. What is the priority nursing action? Question 5. Which specific side effects should the nurse monitor for in a child receiving cyclophosphamide? Question 6. What is the position for a child post-lumbar puncture? The signs of leukemia can be summarized by the ANT mnemonic: anemia, neutropenia, and thrombocytopenia. The priority nursing action is neutropenic precautions, with strict hand washing being paramount. In summary, leukemia is the proliferation of immature white blood cells. All L is the most common type. Diagnosis is by bone marrow aspiration. Treatment is multiphased chemotherapy. Nursing care prioritizes infection and bleeding prevention and managing side effects, especially the emergency of tumor lysis syndrome. Thank you for joining this masterclass. The next topic will be Wilms tumor, or nephroblastoma. You can find more resources in the recommended readings. Thank you for watching this video. Keep working hard, your uniform is waiting.